السلام عليكم ورحمة الله.
وعليكم السلام ورحمة الله وبركاته.
Good evening. How are you? Are you okay?
Alhamdulillah, okay, inshallah.
Selamat malam. Today we have four presentation about dermatology, yes?
Yes.
So what did you prefer, to do two and then pray Maghrib, or try to do the four and finish bit early?
Depends on how long it is.
Yeah, so it depends on you, not me. I am ready, no issue. Okay, let us see. It may be after the second presentation. If Maghrib came, we can go about 5 to 10 minutes and then continue again. Okay.
Sounds good.
Okay, let us start by Umm al-Kitab. Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alamin ar-Rahman ar-Rahim. صراط الذين أنعمت عليهم. Before I forgot, I need to make one more presentation, how to examine clinical examination of the skin. Okay, it is very important because the other system we know the flow, inspection, palpation, percussion, auscultation, like that. Okay. So the four presenters today, inshallah, need to sit together and do one job like that, cutaneous examination. Okay, let us start now with which topic?
Hemangioma.
Hemangioma. Okay.
Infantile hemangioma. Yeah.
Okay.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Nakib bin Mohsin and my metric number is 1812001. So my topics for today is hemangioma. Next. This is the outline for today. Next. So by the name of hemangioma, you can have an idea about the disease, where hema means blood, angio means vessel, and oma means tumor. So hemangioma, it is a benign proliferative vascular tumor. And this benign tumor, it arises from the proliferation of the vascular endothelium. And it has a characteristic that marked by an early proliferation, followed by spontaneous involution or spontaneous regression. And as I said, it is a benign tumor, so it is rarely transformed to malignant. And the birthmark, it is usually bright red birthmark that appears at birth or in the first or second week of life. Next. So for the epidemiology, hemangioma, it is one of the most common tumor for infants. And 1 out of 10 babies may have hemangioma, and it is more dominant in girls compared to boy infants. And the risk factor to have this hemangioma, usually in premature babies, in a low birth weight babies, and also in a multiple birth. And it is not inherited disease. Next. So for the pathogenesis, basically there is no established pathogenesis for hemangioma, and also there is no causes for hemangioma to be developed. But there is a lot of theories, and one of the theories suggests that if when the patient is in the hypoxia state or hypoxic state, they may develop hemangioma. This is because during the hypoxic state, it may induce the release of hypoxia-inducible factor 1 alpha. And this factor 1 alpha will induce or will cause the transcription of others angiogenic factor, for example, like vascular endothelial growth factor, GLUT1 factor, and insulin-like growth factor 2. So all of these angiogenic factor, it will enhance the proliferation and differentiation of the endothelial cell and causing the development of the benign tumor. And in the proliferating phase, it is stated that it may occur due to a homeostatic attempt in order to repair the hypoxic tissue. And regarding the involutional phase or the regression phase, there will be no specific time for this phase to occur. Means it occur randomly, and the involutional process, it will be unsynchronous. Means the tumor, part of the tumor will will undergo regression, and another part of the tumor will continue to grow. Next. So for the clinical cause, like I said, this hemangioma have two phases, which is the growth phase and also the involution phase. So as you can see at the right hand side, the graph shows that commonly at age of 4 to 8 weeks, there will be a rapid growth phase. Means the tumor will grow rapidly and achieve the maximum size at 6 to 9 months old. And after the rapid growth, the growth will slow down, as you can see in the graph, slow growth, and then reach the static growth. So after, to know that the patient hemangioma is in the static growth, the characteristic of the tumor, it will be more compressible and more soft. And the last phase is the regression phase. It usually starts at 2 years old, and it will begin with a paling of the color of the tumor, as well as followed by the flattening of the papule. And for the maximal regression, different patients have a different time to achieve this maximum regression. Means the tumor is fully diminished. So some of the patient may achieve the maximum regression at 5 years old. It can also be at 7 years old, and mostly at 9 years old. So the characteristic for the skin after the tumor is fully diminished, it may have hypopigmentation, fibrofatty deposition, as well as scar if there was an ulcerated tumor. Next. So these are the subtype for infantile hemangioma. So the first one is superficial hemangioma. So it is the commonest form of hemangioma, and it accounts around 50 to 60%, and also known as strawberry or capillary hemangioma. So this is because the characteristic of the tumor itself, it resembles the strawberry color and shape. So the characteristic of the tumor, it will be a bright red papule and sharply circumscribed, as well as compressible, means the tumor is a bit squishy. So it will reach the maximum size at 6 to 8 months old. Next. And for deep hemangioma, it is the less common form of infantile hemangioma. It accounts around 10 to 15% of the cases. And the presentation of the tumor, it will show a slight bluish discoloration on the skin, and there will be a soft and warm mass that is more diffuse and less defined. So the color will be slightly bluish. This is because the tumor is not developed on the skin, but it developed subcutaneously. Means there is a skin overlying the tumor, and it will reach the maximum size at 12 to 14 months old. Next. Next is the mixed hemangioma. It accounts around 25 to 35% of the cases. It consists the characteristic of both the deep and also the superficial hemangioma. Means the presentation of the tumor, there will be a bluish discoloration as well as the bright red papule at the same time. Next. And the last one is multiple neonatal hemangiomatosis. So it accounts around 15 to 30%. It consists of multiple small lesions that range in size from a few milliliters to 1 to 2 centimeters. And this lesion can develop all over the body. Next. So this is the picture to differentiate between the superficial hemangioma and deep hemangioma. As you can see, the deep hemangioma, the tumor is developed underneath the skin, means there is a skin overlying the tumor. That's why it shows a slightly bluish discoloration on the skin. Next. So for the clinical features, different patient will have a different time for the clinical manifestation to arise. Means some of the patient can, the clinical manifestation can arise at birth, but mostly it will arise at 2 to 4 weeks age of infants. And the location for the lesion usually develop at the head and neck of the patient. And most of the lesion is a solitary lesion. And if the patient have more than one lesion, they have a higher chances to develop or to get a visceral hemangioma. Means the hemangioma is developed not on the skin, but on the vital organ. For example, like liver, that can lead to a cardiac failure. And 1% of these cases can be life-threatening cases, and 10% of them can cause impairment to the vital function, to the function of the vital organ due to their location of development. Like I said before, if it develops in the liver, it can cause a worse complication. And after involution, the residual skin may remain and develop the characteristic like I explained before. Next. So the complication, the most common complication is ulceration. So ulceration, it usually develop during the rapid growth phase. So and it is commonly developed at the hemangioma that is developed on the lip as well as at the diapers area. Means if the infants develop the hemangioma at the perineum, so it is most likely to develop ulcer. So after the tumor is ulcerated, they have a higher chances for superimposed infection. For example, infection by the Staph aureus or Pseudomonas aeruginosa. And next is large segmental hemangioma. So for large segmental hemangioma, this is not the complication for the infantile hemangioma, but the location for the large segmental hemangioma may associate with other congenital anomalies. For example, like face syndrome and pelvis syndrome. So this I will get back to this later. I will explain further later. So and the last one complication is Kasabach-Merritt phenomena, which is a rare complication. And this is a complication of capaciform hemangioendothelioma and also punctate angioma. But this is a more severe cases of hemangioma, and it is a life-threatening condition because of the severe thrombocytopenia that result from the platelet trapping within the vascular tumor. Next. Okay, so for face syndrome and pelvis syndrome, so this syndrome, it is a syndrome where if the large segmental hemangioma is developed at a certain site, it may indicate that the patient may have other congenital anomalies or may associated with other systemic complication. So let's start with face syndrome. So face syndrome, it is considered when the patient develop the large segmental hemangioma at the face, at the head, and also at the neck of the patient. So if DH is stand for hemangioma on the face, head, and neck. So it may associated with P, which is stand for posterior fossa brain defect, or the other name is Dandy Walker. So this is a birth defect which characterized by three characteristics. So the first one is enlarged posterior fossa. There will be a malformation cerebellar vermis, as well as a large cyst in the fourth ventricle of the brain. And then it also may associated with A, stand for arterial cerebrovascular abnormalities. It means that the patient might have aneurysm or stroke. And C stand for coaction of aorta, which is the narrow aorta. And the last one is the patient might have eye abnormalities. So all of these anomalies may associated together with the large segmental hemangioma that develop at the face, head, and neck of the patient. So same as pelvic syndrome, but pelvic syndrome, the large segmental hemangioma is developed at the perineum, or we can call it a perineal hemangioma. So the patient with perineal hemangioma, they may associate with external genitalia malformation. For example, like hypospadias. So or the patient might have micropenis or aphelia, a penile agenesis, or simply said that maybe the baby is born with no penis. Okay, so it also the patient also may associated with lipomyelomenigosil, which is a birth defect of child's backbone, where there is a fatty mass under the skin at the back of the body of the patient. So this mass will attach to the spinal cord and pull downward the spinal cord and cause several symptoms. And next is they also may associated with vesico-renal abnormalities. For example, like vesico-ureteral reflux, or the patient might have imperforate anus, or the last one is skin tag. So skin tag is a painless, non-cancerous growth on the skin, and it is connected to the skin by a small stalk, which is called peduncle. So all of these anomalies, so when the patient develop the perineal hemangioma, it might associate with other congenital anomalies. Next. So for other complication, it also, according to the site, the development of the lesion or the development of the tumor. So if the lesion is in a beard distribution, means the lesion is surrounding the mouth as well as the chin. So it might indicate that there is an involvement of the upper airway. So means the hemangioma might affect the upper airway. So the parents of the patient may complain that their child have a persistent cough, or when we auscultate, we can hear stridor. And then next, if the hemangioma, or if this infantile hemangioma is developed at periorbital area, the patient might develop amblyopia, strabismus, and astigmatism. And if it is developed at lumbar area, uh, the the patient might have imperforate anus, as well as spine anomalies and spinal cord anomalies, for example, like lipomyelomenigosil. Next. So for the investigation, almost 95% of the diagnosis is made based on the history and physical examination, because this patient with infantile hemangioma, they may show a typical manifestation. For example, like the color of the tumor, the shape of the tumor, and the characteristic of the tumor, basically. So this can help us to diagnose the patient of which type of hemangioma. Next. But if after we did thorough history taking as well as physical examination, and we still cannot diagnose the patient with infantile hemangioma, we can do some lab investigation. So for example, we can do a markers that shows the hemangioma is in the proliferation phase as well as the differentiation phase. So for example, we can check for serum vascular endothelial growth factor, the urinary beta fibroblast growth factor, the matrix metalloproteinases, and all of this is the angiogenic factor that cause the proliferation of the tumor. And the last one is platelet count. This is to check for Kesselbach-Merritt phenomena and usually show thrombocytopenia. And we also can do a tissue-specific immunohistochemical markers, for example, like GLUT1 and Lewis Y antigen. So GLUT1 is very specific and very sensitive for infantile hemangioma. This is because other vascular tumor and other vascular malformation will not show GLUT1 positive when we do tissue biopsy. So it is only positive in infantile hemangioma. And the last one we can do is imaging studies. So in imaging studies, we can do MRI. So MRI, it will help us to locate and shows the extension of the tumor. And it can locate both cutaneous and as well as extracutaneous hemangioma. So MRI also can help to differentiate the hemangioma, the infantile hemangioma, with other vascular lesion, for example, like vascular malformation. So keep in mind that vascular malformation and infantile hemangioma is two different things. And next is ultrasound. So ultrasound helps us to differentiate the hemangioma with other subcutaneous structure, for example, like lymph node. But there is a limitation because it cannot locate and show the extension of the tumor like MRI. And the last one is plain radiography. It is useful in order to evaluate the patient that might have the hemangioma that affect the upper respiratory tract. So we can use chest X-ray in order to check for hemangioma that affect the upper airway. Next. So for the histological finding, during the proliferation phase, it will show a non-encapsulated masses and dense cord of mitotically active plum endothelial cell. And the basement membrane will be well developed and there will be a presence of mast cell. So keep in mind that mast cell, it has association with the proliferation phase of the hemangioma because you can always find the mast cell during the proliferation phase. So if the proliferation of the tumor is rapid, so the number of mast cell will be increased. And if the tumor is regressed, the number of mast cell will reduce. This is because mast cell will release interferon as well as transforming growth factor, and this protein will induce the involutional phase to occur. So the tumor will be in a regression state. And then involution phase, the histological finding is there will be an apoptotic endothelial cell. The plum mitotically active endothelial cell number will be reduced. And at the end of the involution phase, there will be a fibrofatty tissue deposited. They might have epidermal atrophy, a scar tissue if the tumor is ulcerated, and there will be a loss of elastic tissue. Next. So management and treatment. So it is rarely indicated to treat patient with infantile hemangioma. So before we consider either to treat or not, we need to determine whether the patient is a low risk hemangioma patient or a high risk hemangioma patient. So the low risk hemangioma patient, the tumor is small in size and it does not cause any functional impairment and unlikely to leave a permanent disfigurement to the body. And for high risk hemangioma patient, the size of the tumor will be large and it will be poor prognostic due to the location, and like it is most likely to leave a permanent disfigurement and causing a functional impairment or involve the extracutaneous structure, for example, like the liver. So if it's involve the extracutaneous structure, the liver, it can result in the high output cardiac failure. So so basically we need to the treatment is not indicated for patients that have no risk to develop complication, does not involve any vital organ, and there is no disfigurement. So next. So like I said, most hemangioma does not require any treatment. So for low risk hemangioma, we just need to wait and watch the progress of the hemangioma. Because this hemangioma disease, it has a regressional or involutional phase where it will spontaneously regress in size and fully diminish at the end of the day. So we need, of course, we need to educate the patient and as well as the parent about the tumor, because we are not treated the tumor, and this treatment only indicated in a high risk patient to develop complication if the hemangioma involve vital organs and if the hemangioma or the tumor leave a disfigurement to the patient. Next. So these are the treatment that we administer to the patient. So the first line treatment is oral propranolol. It is indicated in a disfiguring hemangioma, a life-threatening hemangioma, vision-threatening hemangioma, as well as ulcerated hemangioma. So the dosage you can read by yourself. So and the side effect for this propranolol are hypotension, bradycardia, and hypoglycemia, and others. And if this propranolol, oral propranolol, is not tolerated by the patient or does not have any response to the patient, we can use a systemic corticosteroid, for example, prednisolone. So this systemic oral systemic corticosteroid, it is used to terminate the growth of the tumor and to induce the regression of the tumor. And this usually achieved after 2 to 4 weeks of administration. So when the patient is responding to the treatment, we should decrease the dosage gradually. And most of the patients require this systemic corticosteroid until they reach 1 year of life. Next is intralesional corticosteroid. It is for small bore facial hemangioma. Intralesional corticosteroid, it needs to be handled by an experienced physician because it has the procedure has a high risk of development of ulceration, tissue atrophy, as well as blindness. And next, for other systemic therapy, we can administer interferon alpha to the patient. It is effective to treat the infantile hemangioma, but it has a lot of disadvantages. For example, this interferon alpha is very expensive and it is potentially a neurotoxic, And the side effect, that is almost every case will develop the side effect. For example, like fever, myalgia, and the most worrisome side effect is spastic diplegia. And next. For surgical treatment, we need to evaluate carefully the risk and the benefit of the surgical treatment. It is good to be done on pedunculated hemangioma or hemangioma that cause a functional impairment. But usually we do the surgical treatment to repair the residual cosmetic deformities using a laser surgery or a surgical incision. Next. So the prognosis for the most uncomplicated infantile hemangioma has a good prognosis, and the residual skin remain with dyspigmentation, telangiectasis, atrophy, fibrofatty tissue, redundant skin, and scarring. That's all from me. Thank you.
Naqib,
Yep.
you are doing a good presentation, but still write the
Oh, the
references.
reference.
So
Okay.
we will deduct for that.
Okay.
Okay. You touched already the pathophysiology. I need you not to forget the pathophysiology, but you need to put the pathophysiology of complication. You speak about that. Because Allah said, وَمَا أُوتِيتُم مِنَ الْعِلْمِ إِلَّا قَلِيلًا. Sometimes we don't know the complete mechanism, but we know how the mechanism of complication, or the complication which you speak about, which is heart failure. It can occur because of volume overload. If you are speaking about Kasabach phenomena during platelet consumption, so you need to add it as a part, okay? Because it is very important to understand. It may be the family are not able to understand why my child heart became affected. Is there another problem in the heart? No, it's just overloading like that. So it is very important. Okay. The other important point you are right. The residual skin may remain. It looks very vague in your presentation. I think in the slide in the start, the residual skin complication, because if someone read you, he think that the skin may be done already in some cases. Okay, residual skin complication are very important. Usually, this is a good case to counsel the family, especially for this strawberry one. If you know the progress of the case, you will just tell them, don't worry, mom. It may be increased up to few months or 1 year. It will increase, but it used to decrease after that. Until the 5 year, it may be disappeared. Sometimes they leave residual effect or not, like that. So if you tell the family from the start the story of the disease, it is very good from the medical side. So the family know at the time of increasing, take care, mom. It can be injured and bleed. It can be affect like that, infection. So that is the way of making a good counseling with the family. Communication skills are very, very important for everyone in the medical career. And the one who did this job unprofessionally, usually he make a lot of headache for himself and for the patients. And also he lost reward from the gods. Because the patient coming to you, he needs someone who is more professional and more sympathize and carry a human heart. Okay. Anyone need to ask any questions? Okay, that's good. Thank you, Naqi. Let's go for the second presentation.
Okay. Can you see my slides?
Yes.
Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Arpina Midu Muhammad Zaidi, and I'll be the second presenter. I hope all of you are still awake. We're nearing Maghrib later. Okay, so my topic will be atopic dermatitis, or basically the most common type of eczema. Okay, so let's start. So this is my presentation outline. I know it looks like lengthy, like a long ride, but inshallah I'll try to make this as quick as possible, as concise as possible, sorry. So we'll go from introduction to the management. Okay, so let's go to the introduction first. So atopic dermatitis is a chronic, pruritic, relapsing inflammatory skin condition. And this definition is taken from Nelson Essentials of Pediatrics, chapter 80, because Nelson Essentials have 2 chapters of atopic dermatitis. One under allergy, one under dermatology unit. So atopic dermatitis is the most common type of eczema, as I've mentioned just now. Hence, sometimes it is called as the atopic eczema. Now, AD, or atopic dermatitis, is considered to be a part of what is called as atopic triad. So what this basically means is that these are atopic associated conditions, the 3 A's, which is atopic dermatitis, allergic rhinitis, or hay fever. In Malay, they call it alahan hidung, alahan sesama, as well as another A is asthma. So usually these 3 conditions are associated to each other. So basically when a child has atopic dermatitis, it is expected to have, for them to have either allergic rhinitis or asthma, or even both. From a video that I've watched, they say that to also consider another A, which is other allergies, so food allergies. So this is the atopic triad. Another concept that I find important to know is the atopic march. By march here, basically means march as in the marching band, the sequence march, not march as in March 2020. I know March 2020 has been traumatizing for all of us, right? That was the last time we saw each other in the lecture hall. But anyways, atopic march here is referring to the natural history or typical progression of allergic diseases that often begin in early life. So what are these allergic diseases? This was mentioned just now in the atopic triad, as well as the food allergy. So usually, I'll go through this picture first because this one seems more user-friendly, more easy for you to understand. So this shows like a timeline. So usually a person, a child, when the first manifestation is usually atopic dermatitis in the first few years of life. And then the next, it is usually preceded with food allergy, which makes sense because this was when solid food is introduced to the baby. And this is preceded with rhinitis or allergic rhinitis. And then lastly, it's usually preceded with asthma. So this picture shows more of the timeline, but I find that I should also show you this graph, although this looks kind of scary, but no, this is important as well because this one, even though it shows the progression, everything is in plateau, right? But that's not actually the actual case. The actual case is that usually, the purple one is atopic dermatitis. So usually the first manifestation is atopic dermatitis, and it's usually severe or intense in the first few years of life. And then it subsides. When this subsides, the other conditions started to rise. So this is an important concept. So it's not like eczema and it's plateau throughout the life. No, it's more of like this kind of condition. Okay, so that is the atopic march. Now we go to the epidemiology of atopic dermatitis. So prevalence, the prevalence of atopic dermatitis in children is 15 to 20%, while in adults it's 2 to 10%. So children, it's more of a disease for children, more of a childhood disease. And then the prevalence of AD is said to is increased 2 to 3-fold over the past 30 years. They don't really mention the actual reason, but but I would presume it's because of the increasing triggering factors nowadays. So AD has been increasing 2 to 3-fold now. And then onset, as in...
Sorry, Afriana, is it
Yeah?
Malaysian prevalence or international?
I believe it's worldwide. This is from
Yes, good. You just write.
Nelson.
You must add this is the international.
Oh,
and
okay.
What is it? Okay.
All right. So
Okay.
this is from Nelson, and I will write.
Just there is incidence of disease in Malaysia in one book. You can come back to it. Okay. Good.
Okay. All right. Okay. So that is the prevalence, and then the onset, as in when is the age, when is the symptoms of AD first manifested. So in 50% is manifested in the first year of life, whereas 80% is manifested before the age of 5 years old, as in after first year of life, but before 5 years old. So as we've mentioned just now, the atopic march, atopic dermatitis is often the first manifestation compared to other atopic diseases. Race, all races are generally affected with atopic dermatitis, and then sex, for male to female ratio it's 1 to 1.4, just slightly higher prevalence in female. Yeah. So we go to the etiology. Now, atopic dermatitis is not caused by a single etiology. It's a multifactorial condition. So these are the 3 main etiologies. So number 1 is genetic predisposition, which would consist of filaggrin mutation, which will lead to skin barrier dysfunction. I will explain this in the pathogenesis slides later. And then we have triggering factors, which is a whole list of triggering factors. We have allergens, irritants, extreme temperatures, psychological stress, food allergies. All of those lists can be the triggering factors for eczema. And then we have immunological abnormalities, which this is more of referring to the type 1 hypersensitivity reaction. So from these 3 etiologies, we'll go through the pathogenesis. So for the genetic predisposition, as I've mentioned just now, filaggrin mutation. So when there's gene mutation when there's mutation at the FLG gene, which codes for filaggrin, filaggrin is basically a protein that contributes to the epithelial barrier function, the epidermal barrier function. So when filaggrin is mutated, then obviously it leads to the epidermal barrier dysfunction. The reason why they say that it is associated with filaggrin mutation is that because they discovered that up to 50% with patients with severe atopic dermatitis, they found out that they have FLG mutation. That is why they associate filaggrin mutation with atopic dermatitis. But it is good to take note that not everyone with FLG mutation develop atopic disorders, but it's just that they are associating filaggrin mutation to severe to atopic dermatitis because they found the high prevalence of FLG mutation in those with atopic dermatitis. Okay, so when there's epidermal barrier dysfunction, this means the epidermis is weakened. So quoted from a video that I've watched back then, weak epidermis means pathogens in, moisture out. So pathogens in is referring to this entry of antigens, entry of pathogens, while moisture out means the skin will be dry and cracked. Okay, so pathogen in, so moisture out, skin is dry and cracked. Pathogen in, so entry of antigens or pathogens, which leads to the production of inflammatory cytokines. So when this happens, this will induce the inflammation process, and then will lead to the signs of inflammation to be manifested, such as redness, swelling, and itchiness. Okay, so that is general for genetic predisposition. So for triggering factors, this depends on the factors itself. So for example, for a factor of prolonged exposure to low humidity, this will cause dryness of the skin. And then, for example, use of soaps that are neutral or alkaline in pH, this will end up changing the natural pH of the skin, which is actually slightly acidic which is around 5.5. And then psychological stress. Psychological stress may aggravate the skin permeability function. But take note that although stress is listed here, it is not like you can't have, it's not that just stress alone will lead to atopic dermatitis. No, it's just that a collection of these factors and other etiologies will aggravate the skin condition for those who have atopic dermatitis. All right, and then another one is immunological abnormalities. So this refers to type 1 hypersensitivity. So this is a very simplified way to say about type 1 hypersensitivity. But basically, in type 1 hypersensitivity, just recap the immunology lectures back then. So we have, during first exposure, we have the allergens, right? So this, what's this? This is a Langerhans cell. Langerhans cell, if you remember, is a type of antigen presenting cell. So antigen presenting cells, we primarily have 3 types of antigen presenting cell, APCs. We have the dendritic cell, we have macrophages, and then we have B cell, right? So Langerhans cell is a type of dendritic antigen presenting cell. So from the name, antigen presenting cell, it wants to present the antigen, right? So the Langerhans cell presents the antigen, the allergen or the antigen to, in this picture, it's directly saying T helper 2 cell, but in actuality, Langerhans cell presents the allergen to naive T cell. So when it presents to naive T cell, it also secretes a cytokine, which is interleukin 4, IL-4. So when this Langerhans cell secretes IL-4 to the naive T cell becomes the T helper 2 cells, this one, T helper 2 cells, okay? And then, as I've mentioned just now, antigen presenting cell, we have the dendritic cell, we have the macrophages, and then we have the B cells, right? So B cells, which is another type of antigen presenting cell, wants to present the antigen as well. So this B cell presents the antigen to the T helper 2 cell. So when it presents the allergen or the antigen to the T helper 2 cell, the T helper 2 cell will release IL-4, which leads to a class switch of the B cell to turn into plasma B cell. So if you remember, plasma B cell is the one that will produce the antibodies, right? So the plasma B cell will produce IgE antibodies, and then these IgE antibodies will bind to mast cell through the Fc receptors. So when these IgE antibodies are bound to the mast cell, so when there's second re-exposure of the allergens, this allergen will cross-link with the IgE antibodies on the mast cells. So when it cross-links, the mast cell, it will lead to the degranulation of mast cell, and that is when the histamines are released. So when there's histamine, it leads to the reactions such as itching. So that is basically type 1 hypersensitivity reaction, just to recap. Okay, and then we'll go to the clinical manifestations of atopic dermatitis. Now, the cardinal features of atopic dermatitis is intense pruritus and cutaneous reactivity. Now, I believe from Sunflower textbook, they say that if there's no itching, then it's not atopic dermatitis. So pruritus is a very important feature of atopic dermatitis. And then we have, we have the 3 stages of eczema. Now, this is basically stages. In this case, it's not like a rigid kind of stage. It's not like a person should have acute, subacute, chronic. No, it varies from person to person. It's not that they should have acute stage first and then subacute. No, this is more of to describe the characteristic of lesion. So, for instance, in acute stage, it's more of the lesion is more of intensely pruritic with erythematous papules, whereas in subacute stage, it is erythematous, flaky, and have scaling papules. So this looks drier than this one, right? And then this one, it has distinctive border, where this one, the border is not that distinctive. And then in chronic stage, the important word is leisionification and fibrotic papules. Leisionification is basically when the skin is thick and leathery. So leisionification. Okay, so in Nelson, they don't actually say we have 3 stages of eczema: acute, subacute, chronic. They simply say that newer lesions is usually intensely pruritic and erythematous, whereas older lesions is usually leisionification and such. Okay. And then another thing to take note when it comes to clinical manifestation of atopic dermatitis is the distribution of the rash itself. So because a distribution of the lesions vary with age. So for instance, in infants, the lesions are usually at the face and at the scalp, and the trunk may also be involved, including the extremities. Whereas in older children, it's usually at the skin flexures, such as the cubital fossa, yes, and the popliteal fossa, this one, and then the frictional areas such as neck, wrist, and ankles. Okay. And as for the diagnosis, for atopic dermatitis, we are using the diagnostic criteria of Hannifin and Rashka criteria. This is from Pete's protocol, right? So based on this criteria, diagnosis is made on the basis of at least 3 major features, which are pruritus, as I've mentioned, is a very important feature of atopic dermatitis. And then just now we've mentioned the typical morphology and distribution of the rash. So again, in infants, it's usually the facial and extensor involvement. And then adolescents, it's usually the flexural leisionification and linearity. So it's at the flexures. And then chronic or chronically relapsing dermatitis. So based on the definition of atopic dermatitis itself, it's a chronic skin condition. And then personal or family history of atopy. As we've mentioned, the atopic march just now. So asthma, allergic rhinitis, and yes, all of the atopic march. So minor features is listed here. They reinforce the diagnosis of atopic dermatitis. So, okay. Now, differential diagnosis, I have a whole list of differential diagnosis later on, but these are some of the ones that I would list. So other differential diagnosis would be other types of dermatitis. For instance, seborrheic dermatitis, which is described as salmon red greasy scaly lesions, often on the scalp. Cradle cap. Cradle cap is it's very common actually, and I think you would see it from your cousins, from your nephews, because cradle cap, if I were to describe it as a layman term, it looks like a dandruff on the baby's head, but it's not a dandruff. It's yellowish. Yeah, that's basically scalp dermatitis, which people call it cradle cap. In Malay, I think it's called kerak kepala, I think. And then and napkin area. The way to differentiate seborrheic dermatitis to atopic dermatitis is atopic dermatitis usually the napkin area is spared. And then pneumonia dermatitis, the characteristic lesion is coin-shaped scaly patches, mostly on legs and buttocks. And there's usually no itch compared to atopic dermatitis, which have itch, which is the major feature of atopic dermatitis, itchy. Irritant contact dermatitis, which is described as acute to chronic eczematous lesions. And then there's history of locally applied irritants as a risk factor, and this might coexist with atopic dermatitis itself. So irritant contact dermatitis is the most common type of contact dermatitis, which is basically due to irritants. Oh, it's Margaret already. Okay. Okay. History of, so I bold here, history of locally applied irritants is a risk factor. So this could differentiate irritant contact dermatitis to atopic dermatitis. And then we have infectious skin diseases such as scabies. So this is itchy superficial burrow and pustules on palms and soles, between fingers and on genitalia. But the main difference is that main difference between scabies and atopic dermatitis is the cause itself. So scabies will be presented by Anis later on. So I'll leave that. Okay, so here is a full table I found in Nelson textbook of pediatrics that you may read later. I just want to say that the table exists. Okay. All right. Investigation. All right. So investigation is usually unnecessary because diagnosis is generally made clinically based on the diagnostic criteria just now. But when necessary, some of the investigations could be blood tests. Should I take a rest?
Continue.
Okay. So when necessary, you could do blood tests, which you'll usually see elevation of total plasma IgE level and peripheral blood eosinophilia. And then you could also do allergy tests, such as skin prick tests and radioallergosorbent tests, RAS. So this is an example of skin prick tests. They usually draw like this on your hand, on your arm, and then they number it because they want to put multiple allergens on it to see which one is could cause you, which one is possibly you're allergic to. Whereas at radioallergosorbent test is more of like a blood test, where the difference is that in the blood test, they want to see the elevation of IgE level, whereas the RAS is more of to see specific IgE so that they can identify the allergen. Okay. All right. And then we have the complications. I've listed the ones that I've mentioned, that have been mentioned in Nelson Essentials. So the first complication is, okay, wait. The first complication is increased susceptibility to secondary infection. This is because of the defective cell-mediated immunity. So there's increased susceptibility to secondary infection. Secondary infection. So most common cause of the infection is usually Staphylococcus aureus. And then another complication is eczema herpeticum. Herpeticum, which comes from the word herpes. This is basically an extensive cutaneous vesicular eruption which arises from pre-existing skin disease, which is in this case is atopic dermatitis. And this is usually caused by HSV, herpes simplex virus, herpes, so herpeticum. And then
this one is a life-threatening in infants and the newborn. Take care about it, okay?
Okay. And then we have eczema vaccinatum, from the word vaccine. This is basically a localized vaccinal superinfection of affected skin, and it is caused by smallpox vaccination. And this may progress to generalized vaccinia, which can cause extensive rash, which means the rash is distant from the site of inoculation and it leads to systemic illness. And this actually can be life-threatening for patients with immunodeficiencies.
So is it only to smallpox? Vaccine superinfection?
From what I've read, yes, eczema vaccinatum is usually associated with smallpox vaccination because of the vaccinia.
Why you are speaking about it now? Do I have a smallpox?
Oh, okay, sorry. Yeah, I've literally took this from the book, yeah.
I think you must check other vaccines because other vaccines that can contain some allergens like egg yolk like that can be effective.
Yeah.
It's just a revise, but if it is only smallpox, it would be.
It's not necessary.
Out of fashion now. Hoping
yeah.
There is still a smallpox in the lab of USA kid. I don't know for what, but still. Okay.
Yeah, I literally took this from the book without thinking much. Okay, all right. So that's the complications. And then lastly, we go to the management. So this was taken from the pediatrics protocol. So management, after the diagnosis, we do a physical assessment to check the severity of the skin condition. So usually, so the domination is varies based on the severity of the skin condition. So wrote here clear. So usually for the normal skin, no active eczema, they usually just give emollients, which is basically moisturizers, if I'm not mistaken. Moisturizers specific for sensitive skin and eczema. So brands like Cetaphil, Eucerin, all that, yeah, they usually consider that. And then for mild eczema, they usually give emollients and may give mild potency corticosteroids. For moderate, they basically add up more management for when the skin condition gets more severe. So for moderate, they use emollients, moderate potency corticosteroids for 7 to 14 days. Wet wraps is basically, it could be in the form of bandage, or it could be in the form of like a garment, like an innerwear. So basically, what they do is that, for instance, a bandage, they soak a bandage to make it wet, make it slightly damp, and then they before that they apply a moisturizer on the patient's affected skin, and then they apply the wet bandage to the area, and then on top of the wet wrap, they apply the dry version of the bandage. So that is the wet wrap. Tacrolimus is basically an immunosuppressive drug. It's a topical medication. And then lastly, for severe, we have emollients, moderate potency corticosteroids, wet wraps, tacrolimus, systemic therapy, and phototherapy. I would also like to add another one not mentioned here, but it's usually mentioned in the textbook as well, TCI, the topical calcineurin inhibitors. So they usually consider using that as well, because corticosteroids, you need to take note that they could be side effects of corticosteroids. So that is the simplified management.
So you need to add this one, and you need to add also treatment of complications, because
Treatment complication.
yeah. And I think, did you speak about the antihistamines?
Oh, not yet.
I know this is from our very nice book, but he is speaking about the lines, but there is some points which mustn't be missed, okay? Like antipyretic. Another point, tacrolimus is we prefer, if we are not if we are using any chemotherapy medication as immune modulating, to call it immune modulating drug.
Oh.
Okay, so it is immune modulating, not anti-malignant or anti-tumor. And at that situation, we are using it as a topical, not systemic.
Oh, okay.
Tacrolimus cream. It is eight times, yeah, it is 8 times expensive than steroid, but it is very, very effective.
Oh,
okay. Another one, you must write also the rule of, did you finish management, or still there is something to add?
Yes, finished management.
Finished? So you must speak about the importance of diet control.
Diet control.
Importance of breastfeeding. If there is a family history of allergy, we must insist for exclusive breastfeeding for 6 months, which will decrease the incidence and the severity of the asthma by about 50%.
I see.
You must speak about also the bathing. If you read, if you open just up to date, you will find you can just add some emollient or oil in the skin, so it will help it for moisturizing the skin like that.
Okay.
So it is very important. If you just open the up to date, you will find a very nice point. Yes, this is the core, but sometimes the patient need even some what is this hygienic problem. You must trim the nail. Why? Because the child will scratch. If his hand is not clean, contain staph, it will bring staph.
Yeah.
If it contain herpes, it will bring herpes. So it is very important. Some simple point which can make difference. That's why I need you not to be a normal doctor. I need you to be. You are giving me a lot of positive points whenever I sit with this group and get happy. I need you to be a conclusive stuff.
Okay.
You are thinking as a whole, as if this baby has severe eczema and presented to me, he is my child. I need now everything which can decrease the threshold of the disease. Each thing can help the baby to sleep and let me sleep also beside him. Like that. It is very important. Okay.
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 All right.
Continue. Done.
Yeah.
Okay.
So that is my references.
Thank you. Good. Good. So
Okay.
now we need is it 15 minutes enough for every presenter, or we stop for break?
I think we stop for pray first, doctor, and then we continue
Ask,
so that we
ask,
do not rush things.
is it bulky? Okay. Okay. Let us get 10 minutes. We can just, you can just running some thing beneficial until we come again. Okay.
Okay.
Maybe about 10 minutes, inshallah. I will even pray the fard and keep the sunnah after we finish. Okay. Thank you.
Okay.
Bye.
Okay, doctor. For today, for tonight. Assalamualaikum.
Is it just incident, or because our dermatology is Dr. Anis Shah? Good. Okay.
Yeah, okay. Okay, I continue. Assalamualaikum. My name is Anis. I'm going to present about scabies today. Okay. So this will be my the outline for my presentation. We start with introduction and epidemiology, etiology, life cycle of the causative agent, clinical manifestation, a case report, the diagnosis, and also complications and treatment. Okay, so scabies is a skin infection caused by a female mite known as Sarcoptes scabiei var hominis, or human mite that is characteristically itchy. So the epidemiology for the worldwide, this I obtained from WHO website. Its overall prevalence rate is between 0.2 to 71%, and average prevalence in children is 5 to 9 to 10%. It is endemic in many resourceful tropical regions, or just tropical countries like our country. It is more common in young children and elderly, meaning the two extremes of age. And then if there is recurrent infection of this disease is common. And for the epidemiology of in Malaysia, the overall prevalence is 31%, and this case is highest among aged 10 to 12 years old. Scabies is more common in boys rather than in girls. So based on a study done in Penang in 2010, they found out that in that welfare home, 50% of the boys had scabies and only 60% of the girls had scabies. And also, for information, this disease is called kudis buta in Malay. Okay, so the etiology or the causative agent, which is female Sarcoptes scabiei var hominis, also known as the human itch mite. So it is a small parasite. The size is about 0.3 to 0.45 millimeter long, and 0.25 to 0.35 millimeter wide. This disease is easily spread through close body contact with infected person, meaning a skin-to-skin contact and not just a close proximity. And also it can be infected through contact with infested clothes or bedding, which is the termites. Okay, so this is the life cycle of Sarcoptes scabiei. Okay, so we'll start here. So the female mite will first impregnate on skin surface of human, and then she will secrete a keratolytic substance. Keratolytic substance is a substance that can shed off skin or exfoliate skin, so that she can burrow into the stratum corneum layer of the skin, which is the first layer. And then she will form a shallow well and deposit its eggs, which is about 1 to 25 oval eggs, and burrow fecal pellets, also known as scibala, daily. And then after egg laying for 4 to 5 weeks, the female mite will die in that burrow, and then for about 3 to 5 days, the eggs will hatch and release larvae. And then the larva will move to the skin surface to mold into nymphs. Nymphs is just the next stage of this organism, which is the stage before they are adult nymphs. Okay, and then they mature at 2 to 3 weeks, become adult. So as you know, there are many eggs, so there will be male and female, and they will mate. And then the gravid female will invade the skin again to complete their life cycle. So as you can see here, the male mite is smaller than the female mite. Okay. The clinical manifestations of scabies. Basically, symptom will appear 2 to 6 weeks after the infestation. So the incubation period will be about 2 to 6 weeks, which is about 2 months or more. Yeah, about 2 months. And then the infected person is contagious within those periods, meaning even before they present with symptom, they can be contagious to other people. And then in recurrent infection, however, the symptom will appear much sooner, which is about 1 to 4 days after the infestation. So there are two types of manifestation in human scabies, which is the classical and crested or Norwegian scabies. Okay, for classical scabies, the main symptom is itchiness. So patient will complain with itchiness. It is generalized, very intense, and worse at night. And other signs of this disease is small erythematous papulovesicular lesions, scabies burrows, which it will appear as serpiginous. Serpiginous is a thread-like lesion, which is about 1 centimeter in length. And at this lesion, there will be excoriation marks. Excoriation marks is just a marks that will appear when the patient scratch their skin, and then because of the itchiness. Okay, and then in infants, they can appear with vesiculation, meaning vesicles, small vesicles. Okay, the third sign is reddish brown nodule. This is a less common manifestation of classical scabies, and this type will be known as nodular scabies. So these are the common sites for the clinical manifestation to appear. But in adults, mostly the face, the neck will be spared, but it can happen in infant. So this infant can involve palms, soles, side of feet, and also behind of their ears. Okay, okay, these are some of the pictures that shows the clinical manifestation of this disease in small children. So you cannot really see it, but if you really look at it carefully, you can see a small thread-like lesion in this picture. And this is the nodular type, which is like red brownish nodules. This is also red brownish nodules. And this one, as you can see, it's in the web-like in between the fingers. Yeah, it's a common side. Okay, this is the next type, which is crusted or Norwegian scabies. This is more severe.
In the fingers web is pathognomonic.
I'm sorry, doctor.
In the fingers web, it is pathognomonic. If you found it, it is one of the pathognomonic diagnostic criteria, okay?
Okay. Okay, thank you, doctor. Okay, so the next one is crusted scabies. It is more severe and uncommon, but it can be more common in immunocompromised patient or neurologically impaired individual. For example, those with Down syndrome, or for immunocompromised in HIV patient. So it is highly contagious with huge number of mites, like thousands of mites. So the signs and symptoms, minimal or absent pruritus. This is not necessarily there is no itchiness, but it means it can be that the patient cannot scratch their skin because they are unable to. So does not mean the patient did not complain with itchiness, does not mean it's not there. Okay, so next is diffuse hyperkeratosis with erythroderma, which is a scaly skin. The skin will appear scaly and also red. And then thousands of mites inhabit the crust and exfoliating scales of skin and scalp. Nails may be thickened and dystrophic. Yeah, the nails can look very awful. And some ungual or under the nail debris is densely populated with mites. Generalized lymphadenopathy and eosinophilia may also be presented. Okay, so this is a case report that I found. This report is I got it from this study that has been done in Bali, Indonesia. So this girl, aged 11 years old, came with her mother with chief complaint of discomfort of full body itchiness since 2 weeks. And then according to her mother, the itchiness started from her fingers, and then it increased in numbers, and then it progressed to her wrist, armpits, and back within 1 week. So she complained of itchiness in her lower extremities also, between her toes and knees. And she said that this is the first time she experienced these symptoms. And then she said that it is worsened at night. So this is the clue of scabies. Okay, it worsened at night. And then she said that this complaint did not reduce. And then her mother applied a traditional cream, but it is not relieved also. And then according to the girl, her brother is experiencing the same complaint, the same symptom, which is itchiness. And she said that they have a history of sharing the same room and bed. So this is another clue for scabies, which is other family members also present with the same symptom, which is itchiness. So in this physical examination, uh, the vital signs appear normal. She has no anemia or jaundice, and no ear, nose, and throat are normal. No palpable lymph nodes at the neck region, and other examinations appear normal too. Her dermatological findings: there is itchiness bilateral between fingers, wrist, palm, armpit, back, and her chest. There is multiple erythematous papules, round shaped, sized around 0.2 to 0.1 to 0.2 centimeter. And there is multiple spherical papules around 0.3 to 0.5 centimeter with healed and crusted erosions. There's a few sparaginous papules, which is the Barrow lesion. Okay, so this girl is diagnosed with scabies clinically. So this is her finger and her foot. So for diagnosis of scabies, it is diagnosed clinically, but it can be confirmed with microscopic finding of the mite itself, the egg or the fecal pellets. So this is the egg, and then this is the fecal pellet. Okay, so how can we do this microscopic study is by scraping the skin. So first we apply a drop of mineral oil on selected lesion on the patient's skin, and then we scrape using number 15 blade, and then we transfer the skin to the glass slide, and then we can look it under the microscope. But when I read that when even when nothing is found, meaning you cannot see the mite, cannot see the egg, or you cannot see the fecal pellets, it does not mean that it is not scabies. So it is very important to ask proper history and examination, because it is supposed to be diagnosed clinically. Okay, and this is the differential diagnosis. Um, so these are the manifestations, but that may be confused with these other diseases. So can be papular urticaria, which is an allergic reaction to insect bites or sting. Canine scabies, which is dog type scabies. Chickenpox, viral exanthems, and also drug eruptions, meaning allergic reaction to the drug. And then for eczematous lesion, it can be confused with atopic dermatitis, just like Afina mentioned just now, or seborrheic dermatitis. Seborrheic dermatitis is an itchy rash with flaky scales, because scabies also present with the same presentation. And lastly, nodular scabies can be confused with urticaria pigmentosa, which is a disease that is basically an allergic reaction that patient with present with hyperpigmentation, and also Langerhans cell histocytosis, which is Langerhans cells built up in the body, and it can be presented through the skin, but also other part of the body, which is lymph node or the spleen. Okay, so complication of scabies, it is actually quite important, because untreated scabies can develop secondary bacterial infection due to a scratching of the itchy skin. So when the patient scratch, because it is very itchy, so the patient will scratch it maybe hard enough to injure their skin. So there'll be injury to the skin, and then bacteria can infect the skin. And if this infection, secondary infection, is not treated, it can be so severe that it can cause glomerulonephritis, sepsis, or even rheumatic fever that will further develop to rheumatic. So it is very important to treat viral infection. And also pyoderma. Pyoderma is also a type of actually it is also caused by the bacterial infection, where the skin will have painful sores. Okay, so for treatment of scabies, this to treat the scabies itself. So we will use a topical treatment. So the patient need to apply the topical treatment all over the body, neck down. But if in infants, if the presentation includes the face or the scalp, then it needs to be applied there also. So and all family members or people who had close contact with the patient need to be treated. So this is one of the principle of treating scabies. All of the family members need to be treated too. So and then if treatment is applied by an uninfected person, which is a healthy person, then they need to use gloves, of course. So other things that they need to do is to wash and dry their contaminated clothes and bedding at high temperature, which is more than 50 degrees Celsius, and they need to keep those clothes and beddings in plastic bag for at least 72 hours. This is because the mite cannot survive any longer than that without the human host. So just to be safe, keep it in a plastic bag for more than 72 hours.
And then after the completion of treatment, they need to use, of course, a fresh, clean clothes and bedding so that there won't be any possibilities to be infected by the mite anymore. So an example drug that is used is permethrin 5% cream or lotion. So how do patients use this drug? How use this treatment is by to leave it on their skin for 8 to 12 hours, meaning straight 8 to 12 hours, and then wash it off and then reapply it for in 1 week for another 8 to 12 hours. This is other treatment to treat the itchiness if the itchiness still persists even after the treatment of the scabies. We can use corticosteroid, antihistamines, or emollients. And then for the secondary bacterial infection, we can use systemic antibiotic, which covers gram-positive organism at least for 7 days. And this treatment can be started concurrently with the scabicide, which is the scabies treatment, or we wait for 48 hours. So it depends on the patient's condition. And then, or they can use an antiseptic soaks or bath in impactignised scabies. Impactignised scabies is when the scabies become like impetigo. Yeah, okay. So, okay, these are the list of treatments. So this one, Lindane 1% is also one of the common drugs that is used. But however, this drug can cause seizure in children, so it is not recommended to use in children. So these are the other list of drugs also. You can read it later. So that is all from me. It's just a short one. Thank you.
Okay, Anis. This is an
Yes,
important. This is an important disease which need understanding the situation, especially the social background. That's why we are insisting for every patient to go through the social background, how many person are there, how is the economy, how is the social relationship, how it is very important, because if you didn't catch the index case and manage it well, it will be like a vicious circle. And as you said, it can do a lot of complication, either infection, and it is very worthy because of that patient. Most of them can get glomerulonephritis due to GBS infection. Okay, so it is very important to take that. The caring for clothes are very important. That's why we are trying to advise not to share clothes or use second one. It is unsafe at all. At the same time, because skin to skin and skin to clothes, both of them can cause infection. So it is very important to consider cleaning the clothes and at hot water and ironing it. We prefer to do iron so we can kill it. We mustn't take care that scabies also considered one of the sexually transmitted diseases. So it can be put in the history. I know in pediatric we are not, but it is very, very important. Did you try to check, is it the only way for using permethrin? It is once weekly, or there is another way? Try to check it if I think there may be another regulation now. Okay, just to go through that.
Oh, okay.
Don't miss any cutaneous problem because of its complication looks like other. As you speak about the social history, some area in the body which like this web like that are very diagnostic. Okay, and it is very important. Okay, any questions?
Doctor, actually, I have a question.
Okay.
can I ask you? I'm sorry, but how can we know the skin is already infected with bacteria?
Yeah, if you see the scabitic lesion are very clear. It is, as you speak, according to the area of the skin, it is in the soft area. It is just papular lashes like that. There is no signs of infection, but if started to be red and infected and crusted, and even signs of systemic infection like that, you must suspect secondary infection.
Oh, okay.
Clinical. It is clinical. We are not doing the septic profile for oris scabitic patient unless we suspect clinical infection, because permethrin and the other will do a good job. But if there is infection, of course, we must
Okay.
treat it. Okay, good.
Okay.
Can we
Okay.
go for the last presentation, which is a very important topic?
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Armarif bin Adam Malik, 1818127. I'll be presenting about Steven Johnson syndrome. Next. So this is basically my outline for today's presentation. Next. Next. So I will start with definition, classification, and epidemiology of Steven Johnson syndrome. Next. So what is Steven Johnson syndrome? Basically, Steven Johnson syndrome is a type 4 hypersensitivity reaction or delayed hypersensitivity reaction that typically involve the skin and mucous membrane. For the general definition, it may be defined as severe erosions of at least 2 mucosal surface with extensive necrosis of lips and mouth, and also purulent conjunctivitis. Toxic epidermal necrolysis is a severe form of delayed hypersensitivity reaction that is associated with Steven Johnson syndrome. Toxic epidermal necrolysis is a severe exfoliative disease associated with systemic reaction characterized by rapid onset of widespread erythema and epidermal necrolysis. Next. Even though there is several classifications that have been reported or have been classified, this is one of the simplest classification that we will discuss. That is based on the percentage of the total body surface area involved. We start with Steven Johnson syndrome. There is epidermal detachment occur in Steven Johnson syndrome, but less than 10% of the body surface area is involved. So we can say it is a minor form of toxic epidermal necrolysis. And then we have the Steven Johnson syndrome overlap with toxic epidermal necrolysis, which is there is involvement of between 10 to 30% of the total body surface area. While the toxic epidermal necrolysis itself is a severe form that involves more than 30% of loss of epidermal layer. Next. So we moving on to the epidemiology of the Steven Johnson syndrome. It is estimated to affect 2 to 7 million people each year, and it is more common in older people and women, and it is more likely to occur in people infected with human immunodeficiency virus, HIV, with an estimated incidence of 1/1000 because of the loss of the defense of our immune defense. Next. So we move on to the etiology. There is various etiologic factors have been implicated as a cause of the Steven Johnson syndrome, while the drug being the most common cause to lead to the Steven Johnson syndrome. And we can classify or characterize this etiology into 4 categories. Number 1 is infectious, which is the most common etiology that occur in the pediatric patient. Number 2 is drug induced. Number 3 is malignancy related, and this drug induced and malignancy related is most often implicated as the etiology in adults and elderly. And there is also idiopathic case, about 25 to 50% of the cases, and more than 50% of the patient with Stevens-Johnson syndrome is reported to have a recent upper respiratory tract infection. So there is many drugs that can lead to Stevens-Johnson syndrome, but this is the more common drug, which is the antibiotic such as sulfonamide, amoxicillin, ampicillin, ethambutol, and isoniazid. Anticonvulsant, phenobarbital, carbamazepine, and phenytoin. Also NSAID also is associated with the SJS, like phenylbutazone and salicylates. The infectious agent that is more common to cause Stevens-Johnson syndrome is the herpes simplex virus, enterovirus, adenovirus, measles, mumps, and of course HIV. Bacteria also have been known as etiology of the SJS, such as Streptococcus, Salmonella typhi, and Mycoplasma pneumoniae. Next. So we move on to pathophysiology of SJS. Actually, the pathophysiology of SJS is largely associated with our immune response or our immunological mechanism. It is known as delayed hypersensitivity reaction, type 4, and there is certain population groups that appear more susceptible to develop SJS than the general population. For example, slow escalators and patients who are immunocompromised, especially those infected with HIV and patients with brain tumor that undergoes radiotherapy with concomitant anti-epileptics that are known among those at most risk. What is slow escalators patient? Slow escalators patient are people whose liver cannot completely detoxify reactive drug metabolite. For example, if you give a sulfonamide to the slow escalators patient, this patient doesn't have a complete capability to detoxify this drug. So this patient will develop or produce sulfonamide hydroxylamine with a P450 pathway, and this drug metabolite may have direct toxic effect or may act as heptans that interact with host tissue and then making them antigenic. So this patient will develop sulfonamide-induced toxic epidermal necrolysis. And after this host tissue become antigenic, it will be presented by the antigen presenting cells such as macrophage, and there will be production of the TNF alpha, tumor necrosis factor alpha, by the local tissue dendrocyte, and this will result in the activation of the our immune cell or recruitment and augmentation of T lymphocyte, and then will enhance the cytotoxicity of other immune effector cell. For example, the CD8 plus lymphocyte will be activated, and it can induce epidermal cell apoptosis via several mechanisms, which include the release of granzyme B and perforin. Also, it can induce keratinocyte apoptosis because we can find the CD8 plus cell present in blister fluid. Also, apoptosis of keratinocyte can take place as a result of ligation of their surface death receptor fast with the appropriate molecules, and this can trigger the activation of the caspase system and leading to DNA disorganization and cell death or apoptosis. Apoptosis of keratinocyte also can be mediated via direct interaction between the cell death receptor fast and fast ligand. We can find both of these at the surface of the keratinocyte. And the T cell also known can release soluble fast ligand and interferon gamma, which induce further fast expression by keratinocyte. As there is research done, and researchers found that there is increased level of soluble fast ligand in the sera of patients with SJS overlap 10 before skin detachment or onset of the mucosal lesion. So how this keratinocyte apoptosis is associated with the detachment of the epidermal layer in SJS patient. We know that the death of keratinocyte will cause separation of the epidermis from the dermis, and this will cause detachment of the epidermal layer. And once apoptosis ensues, these dying cells will provoke recruitment of more chemokines and then will lead or perpetuate the further inflammatory process, which lead to the extensive epidermal necrolysis. So that's why how SJS can develop to toxic epidermal necrolysis. So these immune components like CD8 plus cell, CD4 T ligand cell, granulolysin, fast and fast ligand, also cytotoxic T cell, most of them can cause apoptosis of the keratinocyte, that being a most important factor that contribute to the detachment of the epidermal layer in SJS patient. Next. So we go to the clinical presentation. So for the SJS patient, there is typical prodromal symptom such as fever, malaise, headache, arthralgia, also cough productive of a thick and purulent sputum. And there is target lesions. There is contain only two zones, and Nikolsky sign, which is when the skin layer, when we rub the skin layer, the skin layer is very easy to detach. And buccal mucosal involvement, esophageal slaving, also dry eyes. And patient may complain of a burning rash that begins symmetrically on the face and the upper part of the torso. And this lesion core may be vesicular, purpuric, necrotic, and this is surrounded by macular erythema. That is why we call the target lesion that is contained of only two zones. And this lesion may become bullous and ruptured and then leaving denuded skin. And the skin will become susceptible to secondary infection. And this infection, most commonly Staph aureus, may be responsible for the scarring associated with morbidity. Although the lesions of the SJS can occur anywhere, palms, soles, dorsum of the hands, and extensor surface are the most commonly affected. And the rash may be confined to any of the area of the body and most often the trunk. Next. So this is just an explanation what I've explained before. The target lesion contain only two zones: macule that develop into papules, vesicle, bure, utricular plug, and confluent erythema. Center we have vesicular, purpuric, or necrotic. And this is the sign of the mucosal involvement, which is erythema, edema, slaving, blistering, ulceration, airway obstruction. Also ophthalmological complication that may be mild or severe. Next. We moving on to the investigation. So this is an investigation that we can do to confirm diagnosis of the Stevens-Johnson syndrome. Usually minimal dermal inflammatory cell infiltrate and full thickness necrosis of the epidermis are the typical histopathologic finding in patient with SJS. But when we do histopathological examination of the skin, we may also reveal changes in the epidermal dermal junction, also dermal infiltrate that may be superficial and mostly perivascular, and then apoptosis of keratinocyte surely, and we can find CD4 plus T lymphocyte predominating in the dermis and CD8 plus T lymphocyte predominating in the epidermis. CD4 plus T lymphocyte in the dermis, was CD8 plus T lymphocyte in the epidermis. The dermoepidermal junction and epidermis is infiltrated mostly by CD8 plus T lymphocyte. And then we have to do the complete blood count because we want to find whether there is infection that is be a causing agent or etiology of the Stevens-Johnson syndrome, and we may expect to get it to we may expect anemia, lymphopenia, neutropenia, eosinophilia, and atypical lymphocytosis in a patient of SJS that show a sign of some immunological problem in this patient. And then we have to do liver function test. We may expect elevated transaminase and hypoalbuminemia, also pulmonary function to detect whether there is mucosal involvement. We can expect to have broken mucosal slaving on bronchoscopy and interstitial infiltrate on chest X-ray. Also cardiac function, we may have the abnormal ECG and imaging. Also there is a negative finding in direct immunofluorescence. Next. Differential diagnosis. So this is a differential diagnosis that we can consider while confirming the diagnosis of SJS, which is the bullous systematic lupus erythematosus, erythema multiforme, autoimmune blistering disease, also staphylococcal scalded skin syndrome that share some of the features like some of the features of the Stevens-Johnson syndrome, which is the rash. Next. Treatment and management. So usually for the Stevens-Johnson syndrome, most patients are treated symptomatically. There is no specific, no evidence that any treatment can give any benefit to the Stevens-Johnson syndrome. And the symptomatic treatment doesn't differ from that we apply to patients with extensive thermal or chemical burns. And this treatment should be treated with special attention to airway, number one, hemodynamic stability, fluid status, of course, because the loss of the epidermal layer will cause dehydration in the patient, wound and burn care, and also pain control. The most important management that we can do is withdraw the causing agent immediately. We have to detect what caused this disease, SJS, and withdraw it immediately. Usually, we must ask the complete history of the drug history of ask the patient, because the SJS usually develop 2 weeks after the causing agent introduced to the patient. So we must ask deeply and then we withdraw immediately, because this will affect prognosis later. And then oral lesions is managed with mouthwash, and we give topical anesthetic to reduce the pain, so the patient can take the fluid without pain. So because it is very painful to take the fluid while there is a detachment and there is the rash in your mouth, and then because of involvement, so we must give topical anesthetic. And then the areas of the denuded skin must be covered with compress of saline and boro solution, because there is procedure that we do extensive debridement of non-viable epidermis, and then followed by immediate cover with biological dressing, which is the boro solution and saline, to promote wound healing. So this is very recommended in the Stevens-Johnson syndrome, and if the patient is very critical, we can admit to isolation room if possible. And if there is large surface area involvement in the back of the patient, we can give air fluidized bed. And parenteral nutrition is very important to give enough nutrition for patient to replace the protein loss during the detachment of the epidermal layer, and to promote wound healing with enough nutrition. Next. So this is the specific treatment for the Stevens-Johnson syndrome. Number one, of course, eliminate suspected offending drugs. And number two, IV immunoglobulin at a dose of 0.1 gram per kg per day for 5 days. So what is the rationale of giving IV immunoglobulin? The rationale is the IV immunoglobulin is known to block the FAST receptor on the surface of the keratinocyte, and then it will interfere with the FAST ligand mediated apoptosis. So we can reduce the keratinocyte apoptosis that happen through the FAST and FAST ligand pathway. And there is research done, and it show encouraging results when we give IV immunoglobulin in high dose in the very early in the course of the disease and in a short period of the time. Next. So for the monitoring, we monitor the body temperature, monitor the fluids and electrolyte, because the management of the SGS patient is very same like the burn patient. And we monitor the intake output chart, daily weight, and renal profile, because we want to make sure that the patient take enough nutrition to promote wound healing. Next. Prognosis and complication. For the prognosis, the SGS is known as a very serious condition with high mortality, and we can predict the prognosis by the extent of severity at the first presentation. So it's very important for us to withdraw the causing agent, because this causing agent can affect our prognosis. If we withdraw late, so the Stevens-Johnson syndrome can develop to the toxic epidermal necrolysis when we want to treat the patient. This is the mean adjusted mortality reported for the nationwide inpatient sample for 2009 to 2012 in the US. For the SGS, reported for the 4.8%, SGS overlap 10, 19.4%, and 10 is percentage or high mortality disease. Next. Complication of the Stevens-Johnson syndrome, we know that when we lose our first line defense, which is skin, so the patient are more prone to infection. Most commonly, we know that Staphylococcus aureus and then Pseudomonas aeruginosa that can infect the patient with SGS, and this will this will eventually lead to sepsis, and the sepsis will interrupt with all our organ, our system, and can lead to the organ failure. There is also the ocular complication that can cause blindness. Also cutaneous, we can have the pigmentary changes and also scarring because of the loss of epidermis and wound healing, and then we can after the wound healing, there is scarring in the renal. Also strictures and scarring when there is esophagus laving, and then we need to manage the mucosal involvement. We can have the strictures. Okay, next. So this is my references for my presentation. I think that's all from me.
Okay, thank you. This gives us an important clue about the skin. Sometimes skin is not infection, because a lot of us are thinking, is it viral, is it bacterial, is it parasitic? Many times the skin lesion will be autoimmune. So you must put in your index of suspicious for any patient coming to you, whatever the disease, one of the differential diagnosis is the autoimmune. That's why this case may need antibiotic, but it may be also caused by the antibiotics, which is very, very important. That's why we can use many immune modulating drug like IVIG or whatever recommended. It is very important. Okay, don't forget, please, again, the importance of pathophysiology of any disease, which can cover both infectious, autoimmune, malignancy, trauma. All this must be expected, please. Okay. Do you have any questions?
Yeah, Doctor.
Okay, that's fine. See you inshallah the next inshallah session. Hoping we can see you in the hospital soon. Okay, thank you for your good presentation and hoping the best for you inshallah. Assalamu alaikum wa rahmatullah.
Assalamualaikum.
Salam. Thank you,
Thank you,
Doctor.
Doctor.
Thank you, Doctor.
Thank you.
Thank you, Doctor.